Okay, good morning, everybody. My name is Brooke Phillips. I'm the Marketing Manager with Shield Healthcare, and welcome to our webinar on behavioral health and chronic illness. Before we begin, just a few housekeeping items. Attendees will be in listen-only mode, so if you have a question, please type it in the question box on the right-hand side of your screen. There's also a PDF of the presentation slides that you can download, and if you're watching this presentation as part of a group, there are a few forms your group will need to qualify for CE credit as well. This webinar is also being recorded. If you miss any portion of the webinar or would like to share it with your colleagues, you'll be able to find it at shieldhealthcare.com/webinars. Your presenter today is Cheryl Erin with Capital Nursing Education. Cheryl is a registered nurse as well as a family nurse practitioner and a geriatric nurse practitioner among her many credentials. At this time, I'd like to pass the presentation over to Cheryl. Cheryl, it's all yours.
Thank you for letting me talk on this subject. It's a subject that I'm really excited about. I've been working with the chronic care model for over 20 years now in my over 40-some years career. And there have been some really exciting changes with the chronic care model and with behavioral health in the last couple of years, very recently. And so I'm kind of really excited to share those changes. And also, I think as someone who has been working with this for quite some time, I've noticed, and I know everyone I've worked with has noticed, that behavioral health has not been represented the way it should be and treated as best practice in many, and it's just very challenging to do that. I think any of you who are probably listening to this know this as well. So these are our objectives for today. Describe why chronic disease management is multidisciplinary, describe what behavioral health is, as well as really chronic disease management, describe how they interact, identify at least 3 psychosocial barriers to treating chronic disease and behavioral health issues, and I think we'll find a few more. Demonstrate the use of open-ended questions. I know all of us have dealt with open-ended questions, but they can be really awkward and take some practice, and they're a huge component of the chronic care model. And detail 2 strategies to improve patient self-management of chronic disease, and I hope we'll really be able to do a few more than that. Because again, that's what the chronic care model is all about and why I love it and why, again, I've been lucky to be involved in it in one way or another throughout the last, since the 90s. So looking at the beginning then, what is behavioral health? Behavioral health describes the connection between behavior and the health and well-being of the body, mind, and spirit. I think the definition of behavioral health is evolving. To me, in reading and looking at this, I think one of the big differences between behavioral health and mental health is that behavioral health is really substance use encompassing, looking at prevention, intervention, treatment, and also recovery services. So again, behavioral health, I think, includes more of the substance use than mental health. I also think that sometimes the term behavioral health is a little less threatening to people than mental health, and maybe that's kind of a sad commentary. So what's chronic illness? Medicare describes chronic illness as a human health condition or disease that is persistent or otherwise long-lasting. The term chronic is often applied when the condition lasts longer than 3 months, at least that's the way Medicare looks at it. Chronic disease conditions can't be prevented by vaccine. They can't be cured, nor do they disappear. And then over here on the slide, we talk about common chronic diseases that we've all been very aware of. And I think when you think of, in the beginning when we looked at chronic care models, we looked at asthma, diabetes, heart disease, arthritis, and HIV, Hep C. Looking at the definition that we have here, there's certainly a lot more conditions that would meet the chronic illness category, including many geriatric people are discussing aging, though some of us don't like to think of aging as a disease. Center for Disease Control and Prevention states that chronic diseases are the most common, costly, and preventable of health problems. If you look over at the slide, it talks about almost 50% of all adults over the age of 18 have one or more chronic health conditions. So that means in this audience, one of two of you have a chronic disease. And then 25% of adults have two or more chronic health conditions. So 1 in 4 of you have more than two. Prevention is essential to addressing chronic disease, and that's something that we've not done a really great job of, I think. And chronic diseases are the leading cause of death and disability in the United States. I read a statistic last night that 63% of the deaths in the U.S. were caused by chronic disease last year, and 7 to 10 deaths were caused by chronic disease. And I think that kind of shows the impact of what we're talking. So how do chronic disease and behavioral health interact? 18 to 25% of patients suffer from depression following a myocardial infarction. Diabetics are 2 times as likely to suffer from depression than non-diabetics. I can go on and read it, but you can read it. But I think a lot of it is kind of common sense. If you have one chronic disease, it's frightening. It causes anxiety. Many individuals now have 2 to more. A lot of the people I see in geriatric clinics have 4 to 5 chronic illnesses. And we're looking at polypharmacists. We're looking at a lot of reasons to be depressed and a lot of reasons to have anxiety. And often addressing depression and anxiety takes time. And in a primary care model, there again often isn't time to do that. Treatment of chronic disease is costly, accounting for 86% of all healthcare spending. 68% of Medicare spending last night were on individuals that have 2 or more chronic diseases. And again, when we're looking at the interaction between behavioral health and chronic disease, they interact. You look at the risk factors for chronic disease, it's going to be, a sedentary lifestyle. It's going to be a stressful lifestyle, obesity, possibly genetics, possibly substance use. And those are the very same risk factors that we have for behavioral health issues. So it isn't surprising that the 2 interact so much. The good news is that Medicare has realized that chronic care management is saving them some costs and improving care, I hope. So the Centers for Medicare and Medicaid Services introduced an expanded code set for psychiatric collaboration care model and behavioral health integration programs. In 2017, Medicare's chronic care management program expanded so that they can include behavioral health providers. And as of January 1st, 2017, CMS began directly reimbursing clinicians who coordinated care for patients with behavioral health conditions. One of the concerns that I have about this is, since this is new, one, I think a lot of people don't know how to code for it. They're learning. The other thing is I would kind of hate to see separate programs just set up for behavioral health integration programs. We've talked about how the risk factors for chronic disease and behavioral health are the same. And what I would love to see is the 2 roll together so that chronic care models can include psychiatric collaboration, and psychiatric collaboration can include chronic care. Interesting statistics, again, I'm going to have to read to you because I just found them last night and couldn't memorize them fast enough. 30.8% of diabetics have anxiety and depression. Only 5.2% of those were addressed and treated. Asthma, 60.5% of asthmatics have anxiety and depression. only 6.8% of those were diagnosed and treated. And then of coronary artery disease, 48.2%, only 5.7% diagnosed and treated. So we're not doing a really good job in what we're doing, I think, and we set ourselves up for many failures. Medicare has recognized that both chronic care and behavioral health require goal-directed care management in between care management. So you can't just see the patient in the doctor's office. You have to do things in between, patient-centered care and comprehensive care planning. Again, those have always been the direction that the chronic care model has taken. And behavioral health, I think, has worked under wanting to do that, but it's been tough. Again, it hasn't been the way reimbursement has gone. So it's kind of where we're heading to, I hope. So use your words carefully, because what a chronic disease is and what chronic disease are considered depends on who you're talking to. The list has expanded and expanded within the professional community, and now we've got like Hashimoto's thyroiditis is included, Crohn's disease came in. Again, the list is getting longer and longer, and you kind of have to make sure that when you're looking at, especially at reimbursement, that you look at who's reimbursing and what their thoughts are. Behavioral health. The new Medicare Behavioral Health Integration Program, again, that's the program that has been expanded in 2017, is used to support patients in between their visits with practitioners who are treating with patients with conditions such as mood and anxiety disorders, cognitive disorders such as Alzheimer's and dementias, psychotic disorders such as schizophrenia, as well as people with addictions, including drug and alcohol addiction. The new benefit fosters goal-directed comprehensive care planning, care coordination, and monitoring. And again, it very much is the chronic care model, just spelled a little differently. I'm going to talk about some terms that we use with chronic care management. And again, you'll see them also with behavioral health. And just so we all know the language that we're speaking, population management is spoken a lot when you're talking about chronic care management. Population health management discusses a population of people. Kindig and Stoddard, which is one of the leading kind of studies that was done, talks about the health outcomes of a group of individuals, including the distribution of such outcomes. So again, population management is looking at outcomes through a group. And not one size fits all those interventions. The interventions also need to be evidence-based. So again, we're looking at a group of diabetics with a certain, perhaps, hemoglobin A1C or a type 1 versus type 2. Whereas if you're looking at disease management, that's a set of activities aimed at improving the health and clinical outcomes of a population of patients defined by the disease, which I always don't like to define a patient by their disease. I just kind of think that's not a good way to put it. Disease management is moving towards including population management. So you'll hear those two terms. Self-management is probably the most important facet of chronic disease management, and it's why I love the chronic disease model, because self-management is giving back to the patient and their family and whoever is important to them the chance to make their own choices, to understand how their cultural, socioeconomic, and spiritual factors impact their diseases or management of their diseases. And self-management is all about the patient's ability to manage their disease or condition and us assessing how well they're able to manage it and how we can help them do so. So self-management support is what healthcare providers do to facilitate patient self-management. management. And explaining the disease is important. I love this because I have a hard time pronouncing most diseases, so that'll help you when I mispronounce something today. And again, it's allowing the patient to have control. I'm considered a terrible patient by some of the providers that have kept care of me because I always want to row my own boat. We'll talk about that a little bit. And I listen to what they say, but I figure out what I want to do. And some people don't like that. Other people respect it. And I usually head for a provider that'll respect it. Two definitions that I think are very key that we're going to see a lot is adherence. Remember, we used to say non-compliance, and now you'll get your hand slapped. It's more appropriate to use adherence than non-compliant. It's the degree to which a person agrees to and participates in some type of treatment program, ranging from medication to lifestyle changes that it is advised by a healthcare professional. So at some points in my life, adherence for me has not been that good. Persistence is the duration of time from initiation to discontinuation of a therapy. So persistence is very important in medication management. How long has this patient been taking their antidepressants? How long have they been taking their beta blockers successfully? And again, if they're not, I do think the key component to chronic care management and behavioral management is looking at not being judgmental about it, actually talking to the patient and find out why. Money can be a big deal now. Polypharmacy, we'll talk a little bit more about it, but a patient that has 3 to 4 comorbidities, if you're following standard of care in the United States, will have 12 to 14 medications at a cost usually on Medicare of about $400 to $3 a month. So that's a lot of money for someone on a fixed income, and that's a lot of pills. I mean, just think of taking some of those pills you're going to be taking twice a day, some of them maybe even 3 times a day. So that's a lot of pills to swallow. And some people just can't do it or don't want to do it. And maybe we need to discuss that with them. And maybe those pills aren't all appropriate either. So again, part of our team needs to be working with pharmacists on this. Aging population. It's an aging population. I'm aging myself as I'm sitting here. All of us are. And in some ways, aging does meet the criteria for chronic disease. Betty Davis said, getting old isn't for sissies. And I often quote that to my patients. Estimates that about 2/3 of all older adults have more than 2 chronic conditions. And you, again, can read this. I saw a lady in clinic a couple weeks ago, 82-year-old with diabetes, with arthritis, with heart failure, and with, a low thyroid. So a lot of medications, and she probably weighed about 92 pounds. So if you think about as we age, all of our organs, which are muscles, shrink. Those, that's your stomach, that's your spleen, that's your kidneys, that's your heart, that's your lungs. So they're less able to handle all these medications, yet primary providers and providers continue to prescribe the same dose for a 20-year-old that they do for an 80-year-old. And I think that's one of the things. Polypharmacy is definitely something we all need to address. It's always easier to give a pill than to counsel somebody. Equip the patients with problem-solving skills. Let them look at the daily challenge they have with living with a chronic disease. Have empathy. Prioritize them to assisting with organizing the education and considering what's critical for the patient to know. I mean, it's important to figure out what can kill them, and make sure that we set up those stoplights so they know how to handle the danger systems. From there on, we can go slower and we can educate and we can listen to them. And always factor in what's important to the particular patient, especially when you're looking at aging patients. So here's Mrs. Smith. Mrs. Smith likes to know why something is happening with her COPD. She's very like the 82-year-old I saw. The teaching disease process is very important for her. She feels knowledge is power. She's very independent and likes to be in full control. This is the type of a woman you're really going to describe the disease process to her detail, include her in her medication, and the side effects, the burden of cure that she has with whatever medicine she has, making sure you do those stoplights so that she's safe. Now, Mr. Johnson's, on the other hand, he just wants to feel better in golf. He gets anxious when he knows too much, may come to a point where detailed disease progression knowledge, but right now you're going to want to take it slowly. You're going to give him those stoplights again. You're going to let him know what to keep him safe. You need to maybe address that anxiety. You have to speak the language of the culture of the patients you're dealing with, and especially older patients. They may not just come in and say, I'm anxious. They may say, well, I'm a little scared, or it makes me nervous. You need to read them and read their body language. I don't ask older patients if they're in pain. I ask them if they're comfortable, because many patients in their 80s and 90s will deny pain. But I had one guy in clinic say, that denied pain when I asked him if he was uncomfortable. He told me he hurt like hell. Sorry to swear. Equipping patients with problem-solving skills, I think, is key no matter what, and sometimes we have to problem-solve their anxiety. So chronic care management should go through all the silos of care. So from acute hospitalizations to outpatient health care, it should include everybody that's important to the patient, and that could be a neighbor. It's supportive service, caregivers, and disease management should be patient-centered and cross all centers of care. So it's very much transitional care, which is, again, what I love about it. So here's the Wagner model, which is the one that we've all been dealing with since the 90s, really. And you kind of take the Wagner model from the bottom up when you look at it. So you're looking at elements that the most important part is the patient being prepared, being informed, making his own decisions, being motivated. And I would add now into that, I think in these changes in the last 2 years, that we've also looked at any behavioral health issues that patient may have and addressed them as well. And then from there, the team is the next important thing, making sure that the team is educated, that they know what they're doing, and then going to the delivery system design. So look at the best way to use this team, and using evidence care and informatics as well. Wagner was very into informatics. So here's more of the elements: decision support, embedded technology. Wagner's introduced certain pop-ups that you can get as a tickler for either the clinician, or you can do a handout that the patient can get pop-ups of that'll bring them around. So like with diabetics, a pop-up will come out talking about side effects of certain medications, perhaps. Community resources are very important as well, and there may be pop-ups using that as well. Again, this is just looking at the culture of the organization of healthcare. More than 50% of the chronic lives with chronic disease. So one out of two of you guys out there. I love this where it says 90% of disease management is in the hands of individuals and their families. I think that other 1% must be just patients in the ICU that are coding. And so it takes a team. I always love the Village people. Bought one of their vinyl the other day. And again, I think now we have the tools to include behavioral health in that team. So here's the team. I worked rehab for many years as well. So I'm very used to working with physical therapy, occupational therapy, spiritual community. I'm in hospice right now. Pharmacy, counseling, social work. I couldn't live without my social workers. I like to think they couldn't live without me either. So when looking at this, what came first, the chicken or the egg? I don't think it matters. There's a good amount of reason to be depressed and anxious when you're newly diagnosed with a disease. And I think that has to be addressed. And I don't think just prescribing an SSRI is the best way to address it unless it's in a critical decision point for the patient. I read last night again that 80% of the psychotropic medications in the United States were prescribed by primary care providers last year. And again, I think we need to bring in our behavioral health experts more in what we're doing. I gave you those statistics before. We're not referring these patients enough. We're not getting the help that they need to get. So summary of the chronic care model, it's to align and integrate all the elements to improve patient outcomes. And this site, improvingchroniccare.org, is a great site. You go on there, they'll send you CDs. They've got lots of information for people with illness, with chronic illness, and for providers. Maslow's hierarchy of needs I've seen in every single test I've ever taken, and you saw those certifications. I've taken a lot of them, so I included it. But also it's very, very important because even though we're all familiar with it, you've got to really keep it in mind when you're interviewing patients, and also when you're thinking of yourself. If you don't have enough money for food, medications are not going to be easy to come by. If you're not feeling safe, you're not going to be responsive to providers. So again, working from the bottom up, breathing, food, water, sex, sleep, homeostasis, excretion, we've got to look at all of those as we look at the patient's readiness for change. Motivational interviewing is a huge component for behavioral health models and also for chronic care models. It's patient-centered. It's considered a component of health coaching. You're guiding the patient to tap into their inner reasons for making a change. And it engages the patient in decision-making. It's funny, Weight Watchers, which is now calling themselves Wellness Works, is very much using motivational interviewing now. So here's the guiding principles. I actually kind of start at the top and move down. Develop discrepancy. So you look at the gap of where you want to be and where you are now. So, okay, I want to be 20 pounds thinner. Where am I now? What am I now that would be different if I were 20 pounds thinner, okay? Express empathy, not sympathy. We all got that one, I think, but empathy. Roll with the resistance. Don't fight them, It can take a long time for patients to be ready to change. I've had patients that it took 6 years before they were able to quit smoking, and we just worked, and I didn't push them because it would have just got them mad at me and they'd have left. Support self-efficacy. See, that's one of those words I can't say. Develop trust and rapport, very important, and support their goals and action. Find out their why. Why is it important for them? Not why is it important for you. You may want their hemoglobin A1C to be 6.2, but they may just not want to have to get up 6 times in the middle of the night to urinate. And they may not know that the two things are related. So again, that's part of the education. Help them develop an action plan. Decide what's important. Select what they can actually do. Really look at goals that are appropriate and that are measurable and that are realistic. I want to lose 20 pounds, but I'm not going to lose it in a month. So a realistic goal of maybe 2 pounds a month is something you can do that'll make you feel good about yourself. Or maybe just even in the beginning, starting to include more vegetables and, healthy foods into your diet, and always assess for readiness. It has to be their goal, not your goal. Zone or stoplight tools, we talked about a little bit about those. Very, very important. There's simple guidance prompts. You need to evaluate their health literacy before you leave them with them. I still find many, especially aging people, that are reading more at a first and second grade level, and some of these are set up. In fact, most of them I think are fourth and fifth grade level. Never condescending to the patient. You don't know how they've lived their lives. so we can't judge them. And I know that's easier said than done, but do it. I tend to really like my patients and get kind of irritated when people get very judgmental on them. Include an emergency plan. That is key. From the first time I see somebody, I develop an emergency plan that's oriented towards them. And again, part of my emergency plan, I'm hospice, is looking at their life goals and their looking at their goals of care, and provide problem-solving tools for them. And again, whoever's important to them. By the time you're 80 years old, sometimes your family has changed. It isn't necessarily the family you were born with. I think I skipped them. Teach back. Teach back can be very awkward unless you practice it. So, if you go to that site we talked about, I encourage you to practice it. It takes a lot of practice. Teach small amounts. We talk about chunk, check, chunk. So if you're starting to teach somebody to check their pulse, you may just have them find their radial pulse first, show you where it is. That's your chunk, check, chunk. And you've got to make sure that you're not condescending to the patient or making them feel like you're checking up on them. I let people know, hey, I'm just trying to see if I was able to explain this to you right. Can you show me what I showed you, and let's see how it goes. And again, very small amounts, because it's been proven people retain better that way. Trans-theoretical model of change, also known as the stages of change model, often used with alcoholic and drug rehabilitation. I think our behavioral health people are very familiar with this. Open-ended questions, careful listening, looking at nonverbal cues, and again, avoiding pushing. This is the stages of change. Again, I think a lot of us are, we're aware of this. I think the important thing is that it changes. Someone may be ready for change, and then somebody in their life dies or becomes very sick, and they're no longer ready for that change. And we just have to recognize that and respect it, and again, let them row their own boat. So the stages are pre-contemplation, where you're just kind of thinking about it. Contemplation, where you're really thinking about it, where you think you're discussing the consequences of not changing. Preparation to assist in creating your goals is the next one. And then R is to come in there. We come in with the action assist with problem-solving skills. And encouragement, I think, is the most important thing we do, is recognition and encouragement. Oars model of communication is used in models of care, both behavioral health and chronic care. The Oars, the O stands for open-ended questions. A stands for affirmation. You acknowledge their feelings. You focus on their patients. You build trust, and you gain more information and truthful feelings. So open-ended questions, harder than you think. You start them with how, what, tell me about. You encourage the patient to talk more, and you kind of just have to be quiet and listen, which is very hard when you're like me. Try not to start it with why, because that can make people a little defensive. Why do you do it this way? Do you see what I'm saying? That can be cause a little defensiveness. And avoid a monologue. Don't preach at them. If you're doing most of the talking, you're doing something wrong. They should be talking to you. Affirmation statements, again, the A and the Oars. Unless you kind of practice it and find your own way to say it, they can be very awkward. We've all seen them do that. Reflective listening, it seems like you've been very quiet today. It sounds like this illness makes you angry. It sounds like so much information is overwhelming. This is where we can catch the depression and the anxiety, I think. This is where I find it a lot. And then restarting or summarizing. Very, very important. Really, really key. You will see me do that. I think anybody that goes out with me to see a patient, or that is with me in a clinic, will often hear me say, I always say, what could I have done better today? What would you like me to have done? Or could we talk about that we didn't talk about? And I think a very important part of that is don't wait till you've got 3 minutes and you've got to leave. If that next patient is sitting in the clinic waiting for you, or if you're due to be at another home in 15 minutes, you're wasting your time with this. You've got to give yourself enough time that when they come back with something, you've got time to address. Very, very important. So again, the chronic care management principles are teaching primarily respect, good communication, being non-judgmental, and allowing the patient to row their own boat. I kind of love that saying because it's so important. We're so used to telling people what they have to do. They don't have to really do anything. They have to understand the whys and the whats of what they're doing, the burden of cure for the medications they're taking. That's an old Irish thing. And then they get to be the bosses, So, and I always tell them, I won't get mad at you no matter what your decision is. I will support you as much as I can. Chronic care will always be with us. I do think of aging very much as a chronic disease. I'm sorry to say that, but it's okay. I mean, when you learn to deal with these things and you have help and support, life can be good. The effects and interaction changes between chronic care and behavioral health, again, these changes have just come up. 2017 was not that long ago. And I am hoping it was a very small step, but I am hoping it is a step that's showing that Medicare and other agencies are going to do better reimbursement for counseling and recovery for behavioral health issues, that we're going to screen our patients better for behavioral health issues with chronic disease, depression, anxiety, substance abuse issues, polypharmacy. I mean, that comes in there too. People start taking pills of their loved ones because they can't afford their own pills. It gets confusing. More support for behavioral health inclusions and better care for our patients. And we've expanded our village, which I think is an important thing. Patient-centered care. I love this. You've really got to look at the patient. And I know when all of us are as busy as we are, that's tough. And more important than looking at the patient, so looking at this patient would have been really important, is talking to the patient, finding out what's important to them, what they see this impact of them from this chronic disease is. I think that's so key. So looking at our objectives again, and we're running right good on time, I think, here. So describe why chronic disease management needs to be multidisciplinary. Again, we have worked in silos of care before where someone just comes into the doctor's office, goes off, and you don't see them again until they make another appointment to come back and see you. I think we've got to look at including our whole team because chronic disease is complicated. And again, 1 out of 4 of us have 2 to 5 chronic diseases. Describe what behavioral health is. Again, behavioral health is mental health incorporating more substance abuse issues, more recovery issues, and then describing how behavioral health and chronic disease interact. An interesting statistics that I saw last night is that patients with mental health diseases die 25 years earlier than patients without mental health disorders, or behavioral health disorders. I think that's very key. And those, what I thought was interesting too is those causes, the natural causes of death, were pretty much the same as everybody else: coronary artery disease, diabetes, respiratory issues, and infection. Identify at least 3 psychosocial barriers that may need to be addressed in treating chronic disease and behavioral health issues. I think we hit on more than 3, but so certainly socioeconomic, safety can be another issue, culture can be an issue, communication or lack of can be an issue. And again, I really stress this to people. You could be talking to the wrong people. A neighbor may be the most important person to this patient. And if you're talking to a daughter who they see once a year, and they really don't want you to talk to them, that's important to know. Demonstrate the use of open-ended questions and practice them. because we all know about using them, but I don't really see them used a lot, sometimes in clinic and in home care and in hospice. And they can become second nature to you. Detail 2 strategies to improve patient self-management of chronic disease. Well, we talked about motivational interviewing, which I use a lot, and we talked about action plans, and we talked about stoplights, and I think those are very key strategies to improving self-management. I think, again, looking at Maslow's hierarchy of needs so that we make sure the patient is safe, that they have those basic essentials to life, because you're not going to get them to quit smoking. I know people say cigarettes cost so much, and if they can't afford cigarettes, how can they afford food? You know, at that point, they're kind of self-medicating, I think. So again, Maslow's hierarchy of needs, I think, is important. I think Oars strategy is very important, those open-ended questions, those affirmations. I always try and affirm how well a patient is doing. You know, and people have said that about me. You always leave the house, you know, when I come in saying what a good job they're doing. Anybody that is living with a chronic disease is doing a good job as far as I'm concerned. You know, it is not easy. Anybody that is 80 to 90 years old, they've worked hard to get to be 80 to 90 years old. And our younger people that have chronic disease, you know, they get so much condescendence from the patient. It's expensive for them. So again, to me, I don't care if they're still smoking 2 packs a day, they're still doing a good disease. So I'll always be honest with them. So that's pretty much the end of the presentation, and I think we hit it right on time. And as I always say at the end of all my things, is there something you have more questions about, or that I could speak to more for you? And I'll give it back now to the powers that be.
Great. Thank you so much, Cheryl. That was a wonderful, very informative presentation. Thank you for your time. We do have a few questions coming in. If you don't mind going to the next slide, please. That should, I believe, be a slide that talks about how you can expect to receive CE credit.
Yep. Is that the one?
That's the one.
Yep.
Perfect. So we do have one question. Do we need to complete the attached sign-in and registration handouts to receive CE credit, or do you have our information from GoToWebinar? Great question. If you are an individual watching this, we do have your information from GoToWebinar, so you do not need to fill out the attached forms, the registration and sign-in forms. If you're part of a group watching this together in the office or any other place, we only have the information for the one person who initially signed up, so we will need you to fill out those forms in that case, so we can make sure that all of you do get CE credit. And another question, sorry, where do we get the sign-in sheet? That will also be on the right-hand side of your screen. We do have handouts, so just look for the field that says handouts. If you can't find what you need by the end of this presentation, just email us at marketing@shieldhealthcare.com, and we'll take care of it for you. Cheryl, would you mind going to the next slide, please?
Sure.
Great. We just have a few things about Shield, more resources for you and for your patients. If you do visit shieldhealthcare.com, this is where the recording, you'll find the recording of the webinar. So you can go to shieldhealthcare.com/webinars. You can also go to shieldhealthcare.com/community. That's where we have over 2,000 articles, videos, other resources, good information for your patients. You feel free to go to the next slide, please. Oh, great. And we also have educational booklets that are available on shieldhealthcare.com as well. So you can download these digitally, and you can also request a hard copy. And feel free to go to the next slide, please. Great. Okay, so now I'm just going to address some of the questions that are coming in. Thank you so much, everyone. If you do have a question, now would be a great time to type it in the right-hand corner of your screen. One question that has come in, Cheryl, hopefully you can address this. What can be done for a patient who is overwhelmed by meds and appointments who becomes non-compliant with both?
Okay, non-adherent, remember, you guys, and you know what, I don't really care what you call it. Some people just get really freaked out when we say that now. You know, and that's a great question because, again, polypharmacy is a huge issue. There's good statistics showing that of 2 patients with the same disease process, one goes for aggressive care and one goes to hospice, that the hospice patient actually lives longer. And I think a huge reason for that is the first thing I do when I get a patient that's coming in to hospice is I call a pharmacist, and we sit down and we go through their meds with, either me or the medical director, and we look at realistically what meds there are on and what meds they don't need to be on, looking at their goals of care as well. I mean, a statin for a 90-year-old is maybe not the most important thing in the world. Statins cause a lot of arthralgias, bone aching. Statins have a lot of side effects and increasing some arrhythmias. And so again, that's a medication that you can discuss with the patient. Do you really feel like you need this at this point? I mean, the cholesterol benefits are really shown to be in 5 to 10 years. So do they care at 95 and 100 what their cholesterol is that much? Whereas maybe they're aching all over, and if you can take that statin away, they might have less of that problem. Again, you look at the medicines, and one of the things that I found is it's so hard. We have Medicare's guidance on the medications that are standard of care for each disease process. But again, you've got to be realistic. When you've got a patient who's got 4 or 5 comorbidities, something's going to have to give. I had a patient come into a free clinic not too long ago, and he had a blood glucose of over 400. His blood pressure was like 230 over 120. I actually remember that's what it was. And he only came in, he was an undocumented gentleman, and he only came in because his wife made him come in because she knew he took some medicines back in Mexico, and she knew he wasn't taking them now. And another provider who was a new provider saw the patient and came in to me with like 15 medications she was going to write out for this guy, and this guy was not even working. And I said, that's not going to work. He is not going to go get those medications. If he gets them, some of them he's going to be so sick and feel so bad he's going to quit taking them, and you're never going to see him again. So the main thing we needed to do was get his blood pressure down so he didn't stroke out on us, and get his blood glucose down, and then work with one thing at a time. So again, with those patients, we've got to work with them, find out what's important with them, work with a pharmacist. Sometimes you can find one medication that'll do 2 things. You'd be surprised at the interactions you start seeing when you call a pharmacist. So I hope that answers your question.
Great, thank you. I've got several questions coming in, so we'll try to get through as many as we can. Another question that came in, can you give us a few more examples of open-ended questions referring to that slide?
Sure. One that I actually kind of use a lot is, I say to them, can you tell me a little bit about what's bothering you the most about your care right now? Especially if I'm seeing a patient that seems kind of defensive, and it kind of lets them start talking, and sometimes they'll go off on you for a few minutes, but then you can use that thing where you say, I can hear that that's really been bothering you. What can we do so that doesn't happen again? Do you see what I mean? So you're bringing out their conversation, how they feel. Again, you don't want to use why. Why do you feel like that? I see a lot of people doing that. It's going to be more the how. How are you doing this? What is concerning you right now? I do a lot of, talk to me a little bit about what's happening in your life right now. You seem very, I think looking at the visual cues, reading their body language is so important. So important. It's so funny. I have so many people I'll go out with who will be talking to a patient, and the patient will be saying, I'm fine. And it's obvious by looking at them. I don't know if all of you are familiar with the pain ad score, but that's how we can look at a patient that doesn't talk about their pain and figure out what their pain is. These patients have a pain ad of 7 or 8, So again, I hope that answers your question.
Great, thank you. Just going right down the list here. And we do have both healthcare professionals and individuals on this webinar. Are eating disorders being included in addictions?
Yes, they are. That was my understanding from looking at this. Again, they're looking in the behavioral health one. And I think that is a real key component. I'm seeing a lot of 50 and 60-year-olds that we're treating for chronic disease, and I've had a few of them that nobody even opened up that they might have an eating disorder. And actually those 50 and 60-year-olds, a lot of them have been trying to maintain their weight since they were 18 or 19, and they've caused some significant health care issues. And then, bulimics, we see those. I see people that binge eat to try and control their diabetes. So it all interacts, and I think Medicare is finally figuring that out.
Great, thank you. Next question. How can we encourage resistant patients to become more adherent with medication independently?
Again, you guys are going to think I'm so corny, but really listening to them. I mean, and I will be honest with you. Some patients are so tough. Especially when I work the free clinics, we'll get people who they have been on meth and drugs for many, many years, and sometimes I think they burnt out a few neurons. You know what I mean? And so those patients are an increasing challenge for all of us. What I found works is really listening to them, and actually I'll do a little bit of an assessment to try and figure out what their skill level is in writing down things in short-term memory, and then I'll try and work with a family member to set up a way that they can remember their medications. And again, make sure we're not guilty, that we're not prescribing medications that are hurting them more than they're helping them. Many SSRIs will potentiate the effects of beta blockers. So people that are taking an SSRI, that are taking a beta blocker, will find that they're more depressed, actually, and that their heart rate's going down, and they may not be able to vocalize that to you. So you got to really work with your pharmacist too. To me, pharmacy is a key component because we're all experts in something, and I know medicines, but I don't know them as well as the pharmacist does. So again, I hope that answered your question.
Great, thank you. Next question, and I don't know if this is in your wheelhouse, but it says, we have someone asking, what recommendations do you have for the behavioral health patient with bipolar disease and encourage wellness?
Actually the same recommendations that we've just given. I do have several patients that are bipolar that I've worked with for many years, that it's been my privilege to know them and work with them. And, they create some different challenges, but everybody creates different challenges. I work very, very carefully with the pharmacists in them. I work very carefully with their family. And then also recognize that their life changes impact where they're at. And especially, in that readiness to change, how people go in and out. I have some of them, they're very, very good with their medications, and then something will go off in their life, and all of a sudden they're terrible with their medications, and they're acting out, and their diabetes is going out of control. And I have to, really sit down with them. And now it's so nice with Medicare's changes because I'll be able to get them more counseling and refer them out more often. And I think that's an important fact that we've all not recognized enough, is we need to refer to specialties. We really, really do. And it's been hard to find them, and it's been hard to get them reimbursed, but hopefully that's changing. So that's the best I could do with that question.
Great, thank you so much. Next question. Do you feel that healthcare workers become proficient in using motivational interviewing without specialized training? I have found resistance in clinical staff using and practicing motivational interviewing skills.
And I know what this person is talking about. I started out in the 90s actually working with with the chronic care model, with Wagner's model and motivational interviewing. And I'm a very down-to-earth person, and in the beginning, some of it seemed really strange to me, and I was kind of resistant. But I think if you impress with your staff that they need to tweak it so that they're comfortable with it. You know, you just don't come out and say, I feel that I'm seeing you're more anxious. You know what I mean? You figure out how it works for you to say it, and let your staff know that they're welcome to play with it and figure out what's comfortable with it. You know, if they have a set dialogue, they're going to be resistant because they're human beings, just like our patients are human beings. So I think it's important, and I think practice. I've been practicing this now for over 20 years, and I've had people tell me I'm darn good at it. And I say to them, even if a monkey does it long enough, they get pretty good at something. So I do think you just tell them to it's about trying to provide the best care for their patients, and we have to listen and observe. And motivational interviewing is a great way of trying to figure out where they are and how they can get there and how they can get to where they want to be, not where we want them to be. And that's why I actually have come to be a big proponent of it. And, you know, I teach it myself. But you've got to tweak it to where you're comfortable with it. And I hope that answered that question.
Great, thank you. Next question. In anxiety, are anxiety and depression seen just as frequently in the pediatric population as in the adult population? And what behavioral health issues do you see more with pediatric patients?
Anybody that's looking at me now sees me nodding my head. You know, I did a clinic at UC Davis where I was working with urology, and then I worked rehab a little bit with Shriners too. And yes, anxiety and depression on children with chronic disease and without chronic disease is huge right now. A lot of those kids that I had coming into urology because they were having UTIs so frequently, and their parents wanted operations because they thought they had problems with their ureters and stuff, were constipated. I know that sounds crazy, but these poor kids were afraid to go to the bathrooms at their schools, and so they were holding it all day long, and they were so constipated that their little bladders couldn't work. You know, I think depression and anxiety with children is so undiagnosed and untreated. And again, I'm not a big fan of just throwing a pill at somebody. I think you have to talk with them, talk with the families, and work with them. But especially a child that has cerebral palsy or that has a traumatic brain injury, or I worked with the traumatic brain injury clinic, and I was shocked at the amount of kids that came in that had undiagnosed depression with traumatic brain injuries. You would think they would be looking for it, but people were just not screening. So again, I think it's got to be key for all of us. This is the crazy world we're living in, and I do think the children in this world are having to adapt to it.
Great.
And I hope that answers.
Yes, thank you so much, Cheryl. Next question. I understand we're pushing right up against 10 o'clock here. So if you ask a question and we don't get a chance to answer it today, we will do our best to reach out to you directly and answer your question and also your comments. We have a lot of several personal comments that have come in, so thank you for sharing, and we'll make sure to reach out to you about those. The next question, I practice in the emergency room with a limited time interaction with patients. What do you recommend I focus on?
Well, and you know, I worked in emergency room at UCD for like 10 years, so I know what you're saying. And again, you know, it's a tough one because, you know, when you're triaging, you want to just keep people alive as much as you can. But some of the things that I still will go back to the emergency room, sometimes they have me teach a little bit there. And so I do where I try and actually sit down and talk with the patient. You know, if I get a patient that, you know, like the gentleman I talked about in clinic who his blood sugars were in 400 to 500, he's going to be there for a while because we can't send him out with a blood sugar like that. So during that time, I do try and really listen to the patient and do a little bit of motivational interviewing. I know it sounds crazy, but it actually works. And I know some of you may have heard of mirroring. It's a technique that we do in the emergency room to kind of bring people down slow them down, get them to listen to us more. I will often sit down and mirror them and then come down. And then again, it's about really, even in the emergency room nowadays, not every patient is a major trauma. You know, in fact, as you know, I think most aren't anymore. That's very key. The other thing that's very, very key that I want to mention is trying to provide feedback to their providers in some way. You know, we have all got to get where we transition these patients more appropriately, or they're just going to keep being frequent offenders. Very important. I also really want to recommend that everybody go to that chroniccare.org site that really wants to learn more about this. It's a great site. I've had them send me all kinds of stuff. And over the years, I've really worked with them, and I have gotten a lot of help from them. And a lot of this is, you know, thank God for Google, don't you think? And so, again, I hope I answered that question.
Great. Thank you so much, Cheryl. And just out of respect for the time, we are going to stop it here. But again, we will do everything that we can to get back to you if you did ask a question. If you missed any portion of this any portion of this webinar, it is being recorded, and you will find it on shieldhealthcare.com along with the slide deck if you were looking to download the slide deck. If you are expecting to receive CE credit, look for that in your email in the next 5 business days. If you don't receive it after that point, please reach out to us at marketing@shieldhealthcare.com, and we will make sure that we can get that to you. That also goes for certificates for people who may not be interested in the CE credit, but they want proof that they have attended this webinar. So again, thank you so much, Cheryl, for a wonderful presentation, and thank you everyone for your time today. Have a great rest of your day.
Thanks, everybody. Thank you, Brooke.